Okay, and we're live. Hi, and welcome everyone to the African Pharmaceutical Review podcast, where we bring you insights from the pharmaceutical industry in the context of Africa as a continent. So, it is World Mental Health Day, and therefore, in this episode, we'll be looking at the intersection between mental health and substance use disorder, or some may call it drug addiction, and the role pharmacists can play in the fight against the disease. So my name is Bevin Lekoyani, pharmacist and editor at African Pharmaceutical Review, and I will be your host today. So I'm thrilled to be joined by a young pharmacist, Dr. Elizabeth Muritu, who works at Karuri Hospital Methadone Clinic, one of the medication-assisted therapy or MAT hospitals tucked in the heart of Kiambu County, Kenya. So welcome, Dr.
Thank you. Thank you.
All right, so we'll jump right straight into it. So, Doc, what is a MAT
Yes.
clinic and how did you end
Mhm.
up working in one?
So AMAT clinic is in full what we call medically assisted therapy. So a lot of confusion sometimes. I remember when we first started our clinic, and we would send some of our patients to the referral level 5 hospital in Kiambu. And some of our referral letters would get lost, or rather like lab requests, because they would be taken to maternity. So whenever people hear the word mat, just to demystify, yeah, it should be medically assisted therapy. And that stands for the use of opioids as a substitution therapy to try and replace the harmful opioids that sometimes there is, this dilemma of whether to call them clients or to call them patients. Yeah, they prefer the word client. So those that have been using drugs, in terms of particularly the opioids that are harmful, such as heroin, which they usually inject. So we are able to use opioid substitution by virtue of using methadone or buprenorphine to be able to replace the harmful opioids. So they are able to use these relatively less harmful opioids because they are able to use them orally, like the methadone, and the buprenorphine they are able to use sublingually. That means their quality of life is able to improve because they don't spend their lives looking for these harmful substances. And so they're able to come just once a day based on the duration of action of these drugs. Like methadone, you'll notice is every 24 to 36 hours, compared to heroin, which has a very short half-life of around 4 to 6 hours. For the buprenorphine, could go for a duration of even up to 72 hours in our body. So they are able to now use these opioids to replace the harmful ones. Therefore, we are able to reduce the rate of transmission of HIV, which, as we are able to see, according to NASCOP survey that was done in 2020, the rate of transmission of HIV is around 3 to 4 times higher in these clients who actually inject drugs. Yeah, so we are able to use the less harmful ones, which they only use orally, to be able to manage the withdrawals that they get once they are addicted to those other harmful opioids. And besides using the drugs, which is now the methadone and buprenorphine, it's very important to be able to note that we also do what we call psychosocial intervention, that we actually do social support. So we have quite a number of social workers in our program. We are also able to do counseling, hence the psychological support part. Therefore, this contributes to around 80 to 90% of the change, actually. So it's something for us to note that if I give you all the methadone in the world, I have managed the withdrawals, but I need to be able to take care of this other part of behavior, which is taken care of by social integration and the counseling that our counselors are able to take you through. Yeah, so that's basically what we do, managing opioid dependent clients using less harmful opioids. Yeah.
Yeah, I think MAT clinics are the cornerstone of rehabilitation,
Mm,
especially when it comes to
mm,
opioid addiction. And I remember the first time I heard about it, of course, before I became a pharmacist, that concept
mhm,
literally didn't make sense to me. So you're giving someone
mm,
opioids who's already hooked on opioids.
mm,
But of course, as we later went into school and found out, these are synthetic, the likes of methadone, they actually are key in terms of recovery.
mm,
So I was looking at a certain report, a survey done by Nakada, and what I noticed was that the initiation stages for clients, as you've referred to them as, it's for some of them it quite starts quite low. I saw
Hmm.
that for something like tobacco, uh, kids start as early as 6 years, heroin as early as 18 years. So, in your experience, Doc, what would you say is the main driver that pushes people towards substance abuse and specifically opioid abuse?
Specifically opioid abuse. So the reasons for using drugs, not particularly for opioids, tend to actually cut across. Um, Interestingly, in our Kenyan setup, for instance, quite a number of people are hooked to heroin through the starting of smoking of weed, or what we call bang. I don't know what different countries call it. Yeah.
Cannabis.
So cannabis, yes, the more scientific name. So they start using cannabis. So what the suppliers are doing, they actually lace the cannabis with the heroin, for instance, because they know
Oh,
heroin has a very short half-life. So I am sure that once you start using that product that has the heroin, I can always have you as a customer once you're addicted every 4 to 6 hours. And so I am sure of an income out of that. So some of the reasons that make people to start using anyway, generally drugs, we see a lot of poor relationships in families. Yeah, where you find some of the children have, poor support and poor guidance from their parents. There is also a lot of peer influence. Yeah. And just before I leave the previous part, it would be interesting to note that you'll notice quite a number of our clients, almost 70 something percent, and especially the men, because they are the highest number, 90 something percent, you'll find that they do not actually have a father figure who was able to kind of direct them and be able to kind of be a bit strict in terms of the guidance. So, as I said, poor family relationships. Some of them even have grown up in families where parents are also using. So, availability of that drug, it's very easy to be able to find it. There's also peer influence, okay? There are also childhood trauma experiences that people have gone through. Probably it cost them also mental health disorders that we've already mentioned that they have not been able to deal with. And then you realize later that because they have not dealt with that, they run into drugs to be able to kind of cope with the situation. So I think those are some of the major reasons that I actually see for use of drugs. Yeah.
wow. The thing is, when I was growing up, um, I knew like even if I was to be influenced or peer pressured into drug abuse or something, the one
Mm,
drug I knew I wouldn't try is heroin. And
heroin, yes.
the reason is I've always thought that heroin is this drug which is expensive or something, or heroin, cocaine, those are drugs that are expensive. They are quote unquote
Mm,
a rich man drugs of choice and all that. But
yeah.
I think through my research I found out that it's not really the case. So Doc, how much does
Yes.
heroin in your experience cost in Kenya?
How much does it cost? Not from seeing it, it's good to demystify.
Of course, of
However,
course, of
because I
course, just based on your experience. Because I've always seen, and the reason why I'm
mm,
asking this is because um, you find that the people who are abusing drugs are not extremely well off. You understand what I mean?
mm,
And
yes, yes, yes.
they, you find people who are regular Joes, but they're still able to find a way of getting these drugs. So these drugs can't be 200,000 shillings or $1,000 per pop. So how much? Do you have an idea of how much
Yes,
um,
it costs.
these drugs are cost?
Yes, I do have an idea. Like in the Kiambu County setup, for instance, which would represent more or less the Kenyan setup because the range
Yeah.
is around the same. you'll find a sachet for which you can scoop with your, let me say, your little nail, the fingernail,
Yes.
amount as little as that you're able to scoop in one sachet. It goes for a range of between 100 to 150. How much do these clients use? Remember, there's something called tolerance. So I may have started with one sachet, and then I realized that one is not able to sustain my level of addiction. So you'll find some clients that use even up to 20 sachets in a day. Yeah, that tells you multiply 150 times 20. For instance, somebody may end up using up to 3,000 in a day
Wow.
for the drugs only. What does that tell you? And I get your concern when you say that some of these clients do not seem to be coming from well-off background. So what happens is that the rate of crime is very high among the people who use drugs. Those are the kind of guys who will pickpocket you, or whatever it is, because withdrawals has set in. I am already now sick because I am addicted. I either have to get that money or get it. So that is where the concept of the crime rate becomes very high among these people who actually use drugs. So it's not that they have it. They will get it from somewhere. Some of them now have stolen whatever it is they can steal from their homes. They probably do not even have good relationships anymore with their families. And now, when everything is over at home, they have sold whatever they have and now gone even into the neighborhoods. So that's how they are able to sustain their drug
Afford.
use habit. Yeah.
Wow, wow, that is so eye-opening. Like 150 shillings, but as you said, the
Yes.
short half-life, they end up spending 3,000 shillings. There's this place
Mm,
in Coast.
mhm.
I don't want to
Yeah.
mention the exact term because I don't want to be told that I'm defaming a city. But there
Mm,
is a place where, like, when you're in public transport, you cannot have your windows open, and it's
uh,
an area that is well known for drug abuse. So what happens is
mm,
the people who or the clients who are abusing drugs, they
mm,
usually keep an eye there for people who are exposing their phones or something like that, or can
mm,
pickpocket a wallet or something. So I
mm,
completely understand when you say that these people are willing to do anything to have what you call
mm,
quote unquote their fix, which is which
yeah.
is uh, which is just saddening. So now,
Mhm,
turning back to the MAT clinic or the medically assisted therapy clinics, what
mhm.
is your typical role as a pharmacist in this setup? How do you add value to these clients?
Yeah, so good question, which is very important. Why I am a pharmacist in a MAT clinic. So one of the major roles that I have is to ensure, number one of the things you will understand about people who use drugs is that they have a very poor health seeking behavior. Yeah. So somebody has a wound and you can clearly see it. By the time they, decide I'm going to hospital, and mind you, because of the virtue that some opioids have the analgesic effect, sometimes they're not even feeling the pain. They're supposed to be coughing. Some of the opioids also have the cough suppressant effect. They are not coughing. So you'll find they already even got TB a long time ago. So with the poor health seeking behavior, if I am not very keen on medication use counseling, then we lose it. Yeah. So that is one of the things that we are very keen on. And even with my team, to the extent that it has now become as an area of evaluation, that we need to be very sure how much amount of information can this client actually give me back once I have been able to advise them on how they are going to use drugs. And we do it on the day they come, and even after they leave, say like 2 days later. I need to be sure, because you can imagine as well, if a client has been using drugs say over 20 years, how much effect has that had on their brain? Even in terms of their memory, it's not very good. Yeah. So not to belabor the point, but the point is we need to ensure there is very good medication use counseling. Of course, to also observe any adverse effects, yeah, from the methadone. Like, we recently had a new product that was not going very well with many clients. And we really had to ensure, are the pharmacovigilance forms filled, so that then we're able to send that to PPB, and that makes decisions in terms of the next product that is brought. And from whatever supplier it is. Some of the other things is to ensure that the clients, for the same reason of poor health seeking behavior, unless we can't avoid it, for drugs like the ARVs, because I already told you the rate of transmission of HIV is very high, drugs like anti-TBs, we allow them to take as DOT, directly observed therapy. Yeah, so as I give them the methadone, because they come for it every day, I am able to actually give them these other drugs so that then they are not missing a dose and their adherence becomes very good. What are some of the other roles? The general ones of making sure that I report how much methadone we consumed for the month, how much I have at the moment, how much we need, do proper quantification. By the way, I like to make the joke that this is the kind of clinic you cannot tell the client we are OS. Yeah, because then what are you telling them? You're probably telling them go and use a bit of heroin. Yeah, so it becomes
Yeah.
very critical to be able to do very proper quantification. It's more or less like the kind of quantification we do in the HIV ARVs program. Yeah, but you always need to be very keen and to ensure that your stock levels are well monitored so that you don't tell your clients, I am OS for methadone. Yeah.
And on that point, on being OS,
Mhm.
how do you ensure that, or let me rephrase that, where do you source
Mhm.
for this methadone? Because most suppliers, just like any, and we saw this with the COVID-19, supply chains can get affected from reasons
Mm,
beyond you as a pharmacist.
mm,
You can do all the
sure.
quantification and forecasting, but there are certain
Mm.
unforeseen events that can happen and it will affect your supplies. So, where do you get this methadone and how do you ensure that beyond the quantification and forecasting, how do you ensure that the supply always is there?
Okay, so what we do, we prepare the reports. We have them, we call them the forms P7 and the P8. Then that's the end of every month. And then I am able to send them to a NASCOP pharmacist who is responsible for being able to review them. Once he's comfortable with the quantities that we've been able to do, mostly including 1 month consumption, 2 months buffer, he's able to forward those reports now to the KEMSA pharmacist, having told him, supply this to this MAT clinic, supply this to this MAT clinic. So mostly that's what we do. Well, for us and for where I work, we are a bit lucky. Maybe not for the methadone, but for the buprenorphine, that sometimes our donor program have also ensured we have a bit of buffer. Because like the buprenorphine, which has been a relatively new product in the Kenyan setup, has not been very consistent in terms of supply, even from NASCOP. I think they're still trying to balance now that it's a new product. But our donor program has ensured we have a bit of buffer just to cover for some of those situations. But of course, we use that as a last result. Yes, but I would say so far so good. At least there is not a day I have had to send a client away without their dose of MAT. Yeah,
Oh, perfect. Now, on the
yeah.
same point, what
Mhm.
would you say is the best part about the job you do? What would you say? How do you assess your success? How do you say, like, this is the best part of what I do?
This is the best part. Now, something to be able to demystify and to probably help us even in a better understanding is that addiction is a chronic relapsing brain disease. Okay. So once you have that understanding, you are also able to feel the joy of supporting these clients through their addiction journey. There are times I have been able to see them transformed. Instead of now being in the what we call the dens, which is the place where they do the injecting of drugs and the sourcing of the same, they now have a life. They're taking this methadone once a day. They don't have to inject, so less risk in terms of bloodborne infections. You're able to support them better. As I had mentioned, we try to make our clinics very comprehensive. By that, I mean, I have my methadone here, I have my NCD drugs in the same place. Because once you start telling them, go to OPD to get whatever drug, they will not go. you know.
Mm.
So anyway, once you're able to support them so comprehensively, you've explained to them how they're supposed to use the drugs. They come after 2 days and they are able to repeat the same information, knowing the journey they have walked, you know. It is so fulfilling for me. And also now being able to see them transform, get a job, get a family. I think for me it is quite fulfilling. I actually really appreciate it when I am able to interact with the client clinically, because I also have other, paperwork, supervisory responsibilities. But the clinical part is very close to my heart because I see this client be able to transform and at least have a different kind of quality of life. Yeah. So for me, that's the most fulfilling. Yeah.
And I completely agree because the thing that people probably don't understand is when someone is addicted to drugs, the impact is not just on themselves. The impact
Mm,
transcends into their families, the impact
sure.
transcends into their friends and all that. So when you have this
Mm,
impact and you have this intervention and they're able to get back to work and get back to their families and all that, you see that positivity also cascades to the families.
sure, sure, sure.
Yeah.
That is very
So
true.
yes. Now, on the flip side of that, what is the hardest part of your job?
What is the hardest part? I would say it is not an easy environment sometimes to work in, and especially because, as we said, drug use changes even the functionality of your brain. And so the behaviors of these clients have also not been very positive, like we said, into crime, into using all kinds of big words, if I have to say it like that. So sometimes we are also on the receiving end. We will receive threats, we will receive some abuses. I was making a joke to my boss the other day, telling her, hey, okay, I think in such a setup, we need an abuse allowance, you know? Anyway, of course, with time, with time we have been conditioned to kind of be able to accept them and be able to understand that they won't change immediately. So that is what is able to give you a different kind of feeling even as you serve them. But it is not easy at first, and especially when you come into the program. What else? Sometimes also we have been in a situation where we are almost having no supplies. Probably they are so late or such kind of a thing for buprenorphine. Like I said, were it not for the fact that sometimes you have a bit of buffer, we have been in situations where we don't know how to survive now that it's a new product. So some of those really give me anxiety. I'm like, hey, if I don't have methadone tomorrow, what will I tell my clients? Go and use a bit of heroin. It's usually an anxious moment for me as well. Yeah. So I think those two have been some of the challenges. Yeah.
Oh, okay, okay. Now, the issue of substance abuse. Now, I remember one of the local news stations in Kenya, they did a feature about um, about substance abuse, particularly heroin, at the coast. And for some reason, the coast is really affected by this. I'm not 100% sure about the numbers, but I can almost bet the numbers are quite, or if not, are up there in
Mm-hmm.
terms of being the highest. And basically, they were doing a feature of this girl who, the typical story, a 17-year-old girl met this group of friends, ended up in bars and clubs, and got introduced to heroin. Mind you, at 17 years old. Yeah? And then she's not really from a
Mm,
well-off family, so sustaining sustaining the drug use became an issue. And what I found out from the feature is apparently these clients tend to use or share needles. So, of course, she shared these needles and she ended up um, being infected with HIV and also had a child who also got infected through vertical transmission. And for me, it was such a sad situation. So She was trying to put her life back together, but it was such a sad situation because at the time, I think when they're doing the feature, she had now turned to 19. So imagine at 19 years old, abusing heroin, HIV
Mm.
positive, a baby who's HIV positive. So the point I'm trying to bring out is,
Mm.
in your experience, staring into the face of substance abuse, what is the worst case you have ever seen and you are like, wow, this thing can actually get this bad?
Mm. Okay. So maybe also to comment before I give my response, to comment on the coast situation. You know that it's because the heroin comes in through the Indian Ocean, the sea region. So that's why the numbers there are quite high. And something else about the heroin at the coast, it's also very pure. You know, as it comes this way, I mean, to the upper side, away from the coast, people keep adding a lot of, very bad substances, including talcum powder, whatever it is, to just try and increase the quantity. And money. I don't want to say we Kenyans, but we seem to love money to that extent. Yeah, so I think that's the situation. Actually, at the coast, at the moment, we probably have around 6 to 7 of the mat clinics because of that. And now to my situation in terms of the worst experience. I remember a client we had who was not very young, really, probably in his 50s then, but he started with alcohol, which is a thing that happens with quite a number of our clients. By the time most of them come, by the way, they are not using the, let me say, lesser kind of substances. Things like alcohol are considered lesser kind of substances. They have graduated over time and now to be able to use the heroin. But him, he had used alcohol for a long time. So he comes into our clinic for clients who have a high level of dependence. That is more than 12 months, according to the DSM diagnostic criteria, DSM-5, that talks about addiction. More than 12 months. For him, you see now he had used over 20 years. Okay. Now, when he comes, he already has a heart condition. I think it was pulmonale. And so you want to be careful in terms of initiating this methadone, because one of the side effects is that it can also cause QT prolongation. So you are torn, yet he's already having the withdrawal. So he clearly needs to have us manage his withdrawal. So he has copulmonale. Little did we know he starts having chest issues. Then we need to start anti-TBs. It turns out that he had TB as well. So he now has, we cannot give him methadone because of the heart issues of QT prolongation. He has already been taking alcohol. You can imagine the impact on the liver. The option we have is to start him on buprenorphine. Buprenorphine is also a potential hepatotoxic drug. So, but what choice did we have at that point? Yeah, because we are worried now if we start the methadone. So we ended up starting him on low amount of buprenorphine. But it was not long ago before, he had full-blown acute liver failure. Because imagine being on anti-TBs, think about pyrazinamide and the effect. He now has been taking alcohol for a long time. He's now on buprenorphine as well. So in fact, I'm the one who noticed that these symptoms, he's having hepatic encephalopathy, he's having tremors, what we call asterixis. He was also having jaundice. It was very clear. So we admit him a few days. So he still has withdrawals. So you may still need to continue with a bit of buprenorphine. Anyway, what I'm trying to say is we did everything possible to do the interventions. But unfortunately, having invested all our emotions, all our knowledge, we ended up losing such a client. It's a situation where you feel, what more options do I have? As much as I have all this knowledge, I am trying to put it together, yeah, you wish you could save the situation, but there is not much you can do. So if only when people are getting into drugs, because I know at first it's usually a choice, but then once it gets to addiction, it's not a choice anymore, because you're having withdrawals, you're having cravings once you don't take. But I wish that people actually knew once you're starting to use them, what could be awaiting for you, yeah, in terms of the potential chances of addiction. And something that our clients like to say about heroin, maybe just to scare us a bit with regard to trying it, is that they call it in Kiswahili, nionje unitafute. That would mean if you taste me, you're going to look for me. Yeah, so it feels very nice at the beginning, and very, very soon you're addicted. So it's for us to just be aware. Yeah.
100%, 100%, and I fully agree. People need
Okay.
to
That's fine.
really think about the implications of what may be awaiting you like down the
Mm,
line. So now you had mentioned earlier about
wow.
donors and key players who, through all their efforts, were able to see successes of these MAT clinics. So who are the main partners whose efforts ensure that these programs run efficiently?
Yeah, so as you said, very critical. So far in our program, we have a donor. We have a donor who is called Medicines Sans Frontiers, or what they say, Doctors Without Borders. So they provide a lot of the financial support in terms of, number one, they put up the clinic in the level for hospital to kind of help kickstart. Of course, they work very closely with the county government because the county government was just being supported, but ultimately is to take over because these are our clients. And I like to tell my colleagues, they are our clients. Sometimes when they are coming to the methadone clinic, it looks like they are for Karori or whichever other facility, but they are in our community. So the county government, the donors, we also have what we call the civil society organizations. Like in our case, we work closely with LVCT, who are the people that prepare these clients on the ground, in the dens. They go for reach out programs where they actually talk to these clients about, if you're not ready to come for the MAT program, you would rather get one or two clean needles to use because we have understood that we cannot make the client stop using drugs just by telling them stop once they get to the place of addiction. But through continuous, reaching out to them and supporting them, that's what now the civil society organizations do. But ultimately, once they are ready to come out of the dens, they prepare them for the methadone program. And so they tell them what it is about. Then they bring them for induction into the MAT clinics. Who else? The referral facilities that we work closely with. When we have our clients, because ours is an outpatient rehabilitation center. So by virtue of this, I am actually grateful. I have gotten to interact quite a number of my colleagues in the various referral facilities because we admit our clients there. And it means such clients will still have to take their methadone. So we need to supply such facilities with the number of days the client is there. So they are really supportive and we really appreciate for the same. So I would say those are the major stakeholders. Yeah.
Fantastic. Now, yeah, of course, for any successes, it's difficult to be able to achieve something on your own. So it makes sense to be having these partners to ensure that the overall success actually
Sure.
is achieved. So, and even as we're looking at
Mm.
successes and achievement of goals and all that, what, in your opinion, do you think can be done, specifically in the government sense, in terms of policy and regulation to ensure that this issue of substance use and issue of mental health is actually something that is prioritized. So you find, of course, Nakada does its plays its role when it comes to creating awareness and public education and all that. But I still believe that more can be done. So, in terms
Mm.
of policy and regulation, how do you think it should evolve or should be restructured to ensure that we don't have people dying because of substance abuse or young kids getting into substance abuse, especially from a young age?
Okay. So I would say some of the things that the government can do, of course, like at NASCOP level, I'm sure they have a kitty for awareness. They definitely have a kitty for advocacy. So in the place of awareness, to already, if it's Nakada we are talking about, for instance, are they able to have more people on the ground, explaining to these young people as they start using their weed, their cannabis, yeah, that there are chances that which you think is that could actually be laced with that heroin, for instance. In place of advocacy, you'll notice because of the high crime rate that these clients end up being quite, incarcerated, sometimes from one prison to another. And especially because behavior change is a process. Sometimes it takes some time. But once these clients are there, can we actually have where that now the prison wardens are also well made aware about such clients and how they can be able to support them? They should also be trained to be able to observe for withdrawals and how to easily refer even to such mad clinics, because we work very closely in terms of being able to ensure even a client who is in prison is also supported with their methadone. And we really appreciate, by the way, I forgot to mention, for those prison stakeholders as well, who have been quite supportive in this journey. We would say, in terms of clients who are recovering and doing better, I know it has also not been easy. In the side of PPB, you are aware that methadone, buprenorphine, they are opioids and very highly controlled drugs. But for clients who, have been able to change, they're probably unable to come for their treatment because of, maybe a job or school. We have been able to collaborate. By no, this is an ongoing kind of, policy review, that these clients should be supported such that they can have their dose at home, yeah, as long as we already trust the client, such that they're able to not miss work, not miss school, because we're also trying to improve their quality of life. We are happy to say that we've been able to do that for a number of clients, and we have seen them be able to really transform. So I think those are some of the things that we can do to be able to really support our clients. Yeah.
And that makes a lot of sense.
In the level of quantification,
Sorry, proceed.
sorry for the interruption. In the sorry for interruption. I'm saying in the cases of quantification and the like, for ensuring we have enough supplies, yes, we continue to encourage the donors that have been providing methadone and buprenorphine for free, that they will continue to also not be too tight. They can continue to support us so that we have enough for our clients as long as they are able to, because I know that's one of the gaps that have also been there in the recent past. Yeah.
Okay. So I was thinking about what you said in terms of the prison, and it's something I've always thought about. So there is that correlation with crime and substance abuse, and inevitably these patients get into the prison. So I've always wondered, and it's good that you've clarified that. I've always wondered what happens when such patients actually end up in prison, because I, I don't know. I don't know. Are they really taken care of? Are they really? So it's good that you have clarified that, and policy should be put in place to ensure that there is capacity building at the prisons, and there's more partnerships with the MAT clinics to ensure that the treatment goes on despite what the clients may have done in terms of their crime. So finally, when it comes to this MAT clinics and provision of uh, opioid assisted therapy, how do you see these clinics evolving in terms of technology, in terms of how efficient they can be? How do you see the future like, or how would it look like for MAT clinics, not only in Kenya, but in Africa in general, for them to be more impactful and more effectively run?
Okay. So two things come to mind when you say that. And number one, we've been talking for quite some time about the fact that we need to have a synchronized kind of system. We use a system called the Meta Measure to be able to key in the details of these clients, and we use it for dispensing as well. And so we were thinking a situation where this system is synchronized in such a way that you don't have duplication of clients in some mat clinics, because sometimes they have a tendency to go, assume they defaulted for some time, they go into a different mat clinic and they do not say that I was using, for instance, methadone in a different mat clinic. Maybe they're afraid, maybe they did something wrong and were too afraid to go back. But a synchronized system would help us to easily be able to support our clients such that I'm not afraid. Could they have gone the other side and taken methadone, come here and taken, because now you're worried about overdose, for instance, in such a case? Most of the time, you're forced to do it manually. I have to know that pharmacist in that clinic, call them, But with a synchronized kind of biometric system, it would have been very easy to actually locate. Something I also really hope that we can be able to achieve is that there will not be localized kind of mat clinics to serve mat clients. Rather, because some of these clients, imagine having to come every day to Karori, for instance, some of them coming from a bit far. The amount of cost implications, and considering they're coming every day, and you not sure if you're aware that a client should be on the mat program for at least a year for us to actually say, we've addressed the withdrawals part, we have addressed the psychosocial part, and now we are confident. So imagine having to come every day using your transport. Imagine a situation where there was a provision for there is a measure machine in the main hospital near that client, such that they can now be able to access their Pharmacy and Poisons Board is able to support even such facilities to be able to, they are allowed to also dispense methadone. I look forward to such a day because I think it will make it really easy for our clients. But of course, I know it is not cheap because we need to ensure that the measure machines are well availed. But I think that would be really coming in handy in that area. Yeah.
And I completely agree, because when you bring in technology, of course, it always elevates the level of service.
Mm.
Now, a bonus question.
Mm.
How do you see your career evolving? Do you see your long-term future in mat clinics, or what are your plans and aspirations? Without giving too much out.
So how do I see my career evolving? I would say I am open. I am open because I currently am pursuing a different a master's degree in a different field, not particularly pharmacy. So I am happy to support and mentor others, even in the same field. I know it's a relatively new one. However, I am not too closed in that I want to particularly remain in the MAT program. Actually, it's a nice place for us to exchange, avenues, because like now what I was talking about, sometimes you may need an abuse allowance. You're able to appreciate what are the challenges in a mat clinic as I go to a different place and serve clients. So I am quite interested as well in matters ensuring things are efficient and effective. So I may want to see whether the managerial branch is something I would also want to pursue. Yes, so I am a bit open. I'm not very closed in terms of that. Yeah.
Ah, fantastic. I think and that's a perfect place to end at. So we'll end it there. And thank you so much, Dr. Elizabeth,
Mm,
for sharing your insights. So, on behalf of African Pharmaceutical Review, myself, and Dr. Elizabeth herself, thank you all for listening. And we hope you'll join us in the next episode. See you.
okay. See you. Thank you for having me.